we will go ahead and get started here. Welcome everyone. I hope everyone had a great summer and upcoming fall here, kids back to school. We're here for retina cases from the Lone Star State. Next slide, please, hon. And we are Retina Consultants of Texas. So we're the largest retina-only practice in Texas. We're home to the largest retina research center in Texas, which we'll talk about both those things. This is an exciting meeting for us, very exciting, because this summer in June, we welcomed our colleagues, Retina Consultants of San Antonio. We are now joined together in the largest group in Texas. So both of us, Retina Consultants of San Antonio, formerly Retina Consultants of Houston, are now one Retina Consultants of Texas. And so we'll go through all the individual members and we'll talk about San Antonio a little bit. But not only are we together, but Dr. Baskin, who was my medical school classmate and president of my medical school class and has fantastic slides, will be presenting for us today. So I'm excited to hear what Dr. Baskin has to say. And so we're 20 physicians in 22 locations, both in and around Greater Houston and Greater San Antonio. Next slide. So here we all are. And so this is the Retina Consultants of Texas combined. You'll see Dr. Baskin top left. You'll see Moises Chica sort of upper right. Sarah Holy, Dr. Lane, Gary Lane, Dr. Mine. And I think I got everybody. Those are the Retina Consultants of formerly, the Retina Consultants of San Antonio, now Retina Consultants of Texas. The rest of the people, Dr. Benz will be speaking with us tonight. Many of these other members are on the panel. Dr. Wyckoff, Dr. Shaw, Dr. Chin is here. I think Dr. Nguyen. So Dr. Fish in the top right. A lot of us are here on the panel. Dr. Wong as well, Retina Consultants of Texas. Dr. Larkin, who specializes in uveitis. Next slide. So this is the Houston map, and the next slide, of course, will be the San Antonio map. But if you basically throw a dart anywhere around sort of Greater Houston, around 99, pretty much all the way around, these are our 15 locations. We also have locations in Livingston and a very nice new office in Lufkin, also Wharton and Brenham. But besides those areas, Katy, Pearland, Pasadena Space Center, we have our new flagship office in Bel Air on Newcastle and Bissonnet, basically right where 59 and 610 meet. And we still have a presence in Scurlock Tower, the Texas Medical Center, still have that office. Memorial, 290, of course, the Woodlands, so in Kingwood. The Woodlands and the Medical Center, the Bel Air offices, and Katy are our largest research centers. Next slide. So this is the map of San Antonio. So they've got San Antonio covered, including the Hill Country. So if you have a retina problem in Kerrville, Fredericksburg, anywhere in the Hill Country where you're vacationing, we've got you covered at Retina Consultants of Texas. So they have medical centers all throughout sort of the northwest part of San Antonio, Seguin, New Braunfels, Stone Oak, as I mentioned, Kerrville and Fredericksburg in the Hill Country, Bernie and Alamo Ranch. So all around, essentially from central San Antonio, northeast and northwest, we've got you covered. Next slide. This is our image portal. We've talked about this before, but it's very exciting. And signing up is easy. This is ways by which HIPAA compliant material images can be sent from one doctor to another. So you essentially visit that website, you'll see the registration there, complete a very short, 2-3 minute form, confirm your email, and then we can talk back and forth in a HIPAA compliant manner. So this is the Retina Consultants of Texas image portal designed by us for use to facilitate communications between healthcare providers and ourselves in terms of back and forth referrals, not just you to us, is this a retinal tear, is this a detachment, or does this person have diabetes, I need them evaluated, but also when we do things, we can send them back to you. So it goes both ways. Next slide. We're used to seeing years ago and even recently these sort of poor quality traditional fax. Next slide. And then now we get these bright, crisp, vivid images where you can really see and talk about the patient, again, in a HIPAA compliant fashion. That's the key. Next slide. Our research foundation, the name has changed. The Texas Retina Research Foundation is a 501c3 nonprofit. It is a separate entity financially from Retina Consultants of Texas for both the San Antonio folks and the Houston folks. And again, it promotes education and research related to any macular disease, and it's a nonprofit foundation. So learn more about it at retinaconsultantsoftexas.com, but it's the Texas Retina Research Foundation, largest retina research foundation in North America. Next slide. So Dr. Benz will be the first of our three speakers. Take it away, Dr. Benz. By the way, real quick before Dr. Benz starts, if you have any questions whatsoever, we have active chatters. So ask questions over the chat line. We will answer them. We'll have a dialogue back and forth. Take it away, Dr. Benz.
All right, I'm going to try to take it away here. I'm going to go back quickly. All right, so welcome everyone. Thank you for joining us. I have a nice little case here that I think will help us to talk about a few things. In particular, some of the ways that we can use OCT to help us through and differentiate things about this case in particular. So this was a 64-year-old man that I saw a couple of weeks ago, and he came in with decreased vision in his right eye, as well as distortion. And he said this was at least for 2 or 3 months, perhaps even a little bit longer than that. Pertinent history, he had LASIK in both eyes back in the 1990s. And then he said he had cataract surgery, again, at a relatively young age in both eyes. And so he was pseudophakic in both eyes. On examination, his visual acuity in his right eye was 2200. And in his left eye, he was 20/30. As noted on anterior examination, he had a PCIOL in both eyes. It was well positioned with an open capsule. And on posterior exam, we found the following. So in his right eye, we noted in particular in the macula, we can see some areas of some subretinal hemorrhage, a little submacular gray lesion, and also importantly around the disc, we see some areas of peripapillary atrophy. And though a lot of the action currently is going on in the right eye, it's certainly important for us to have a look at the other eye as well. Now this photo is not quite as good, but we do see some signs of some peripapillary atrophy in this left eye as well. And I think importantly, just as important is what we don't see, which is we don't see a whole lot of drusen and RPE changes and typical findings that we might see in macular degeneration. So imaging for this patient, we did both OCT as well as fluorescein angiography, as well as the fundus photos that we just went through. And we'll review what we found here on the first OCT in the right eye. So again, this was just a couple of weeks ago. And of note, a few things we see here. We see an area, a little patch of submacular fluid. We see some, though not a huge amount of intraretinal fluid or macular edema. And there's a quite large area of hyperreflective material underneath the retina. There's a couple different areas. There's a more solid area and then perhaps another area off to the side. If we remember the way that the fundus photo looked at, this is some fibrosis, this is a little bit of hemorrhage, and then there's obviously just some clear fluid here as well. So there's several different things that we can see on the OCT there. Left eye OCT, we have a little fine epiretinal membrane, but otherwise a pretty good looking, a pretty not terribly abnormal looking macular OCT. And again, of note, not a huge amount of RPE changes, not a lot of drusen that we see here in this photo. Fluorescein angiogram, this is an earlier phase image of the right eye, where we can see some blockage that corresponds to that hemorrhage that we noted on the fundus photo, and also some early signs of a little choroidal neovascular membrane here that lights up a little bit later. A little bit more classic leakage, and also some staining because there's, again, as we noted, some fibrosis that has already taken place here. So we've got a choroidal neovascular membrane in the right eye and myopic degeneration. Even though this patient's 64 years old, this isn't like a classic wet AMD. This is a myopic choroidal neovascular membrane. Important to note because they can act a little bit differently, and how we follow up with these patients can be a little bit different as well. So myopic net versus wet AMD. Myopic nets are oftentimes a bit smaller. They're more likely to have classic leakage pattern on the FA. Pigment epithelial detachments are typically negligible in a myopic net. And as noted on our patient, there tends to be less intraretinal or less retinal edema. So we can see some submacular fluid, some fluid underneath the retina, but typically less intraretinal edema. Treatment for this is relatively straightforward these days. We don't have to go through a litany of what we had done in the past, which would include macular photocoagulation, could include submacular surgery. Lots of different things were tried in the past, but anti-VEGFs work tremendously well. Typically your two first anti-VEGF agents that you would think of in a patient like this would be Lucentis or Avastin. Again, our preference tends to be the on-label medication if we can, if we're able to, and so typically would treat this patient with Lucentis, and this is what this patient received. So treatment for these patients, typically I'll start off with monthly anti-VEGFs. After a few months, most typically 3 months or so, we'll treat and extend. That can vary a little bit depending upon the patient and their response to treatment. And also on the health of the underlying RPE. Now, we discussed this, but sometimes we can transition these patients to treat and observe. These patients aren't always 64 years old. They can sometimes come and present to us at a much younger age. It might be 30 or even younger. And so treatment in a patient with a good other eye forever might seem not that attractive to a younger patient like that. So most commonly, I'll tend to try to extend these patients out to perhaps about 3 months or so. And if we can get that far out, we may have a discussion with the patient about transitioning potentially to a treat and observe type of situation. So any points, any questions? That's my short and sweet case for this evening. If not, we can transition on.
Dr. Benz, I have a question.
Yeah.
For our referral docs that might be counseling younger patients that are high myopes and talking to them about refractive surgery, if they see a bunch of lacquer cracks in the back, do you think it's important that they counsel the patient about the possibility of a net later in life?
Definitely. So you would be presented, or you may be presented with an opportunity to speak with a patient who's got a macular problem, like you note. Now they may be presenting for refractive surgery, but as we know very well as retina specialists, this is a disease that extends to the posterior segment of the eye. So if you find that the patient has lacquer cracks, has pigmentary changes in the macula, has those findings that might make them vulnerable to developing choroidal neovascular membrane in the future, talking with that patient about what to look out for, potentially for the rest of their life, is certainly, I think, a very, very worthwhile thing.
Great case, Matt. Beautiful images. Maybe I'll bring up one question.
Yeah.
The patient like that, concerned, maybe there's some residual changes in vision, decreased vision long term, and they say, what can I do to decrease the risk of this in my other eye? What do you think about vitamins in a situation like this? Is there anything a patient like this should do to protect their other eye, medically or physically, or anything else?
So great question, and there certainly isn't a trial like the IRIDS type of trial that would indicate that vitamins would be helpful. But I would always tell a patient like this not to smoke. I would tell them things about diets. I would tell them things about ultraviolet light and trying to avoid that. And you're right. We're going to have questions about should I be taking those eye vitamins if I've got this myopic degeneration. Probably not going to hurt them, but there's not any data to suggest that it's helpful to them either.
Matt, we had one other question specific to maybe this patient and maybe more generally, how the patient did in terms of their outcome. I know you said it was just still early on in terms of treatment, and it can take a while to get the final result, but either how this patient did or how you kind of expect or counsel patients in terms of their potential outcome after undergoing all this treatment.
So great question. This patient in particular, we're super early on. We've only seen them one time to follow up. The OCT did look improved at their first visit. They were noticing a little bit of improvement as well. With this patient, I did counsel this patient that his visual recovery might be a bit limited because he's got those fibrotic changes under the central part of the macula. Although, these patients with the myopic nets can oftentimes do perhaps a little better than we think they're going to do. And that may have to do with the fact that they have less intraretinal fluid and more subretinal fluid. And there are some studies to suggest that that intraretinal fluid is that may be more disadvantageous for your macula in the long run versus submacular fluid. All right, well, shall we move on to Dr. Baskin's case, perhaps coming up next? I don't know if we want to try to share screen.
All right, can you see
Perfect.
my slides?
Yes, clearly.
Okay, thanks. All right. Hi, everyone. Daryl Baskin here. Excited to present first time. I have no relevant financial disclosures since there's like over 200 people on this, and I probably know a fraction of you. Just wanted to introduce myself. This is me and all of my kids. This is the house that we had built in Africa. My live stream was to work overseas, and we got to do that. And this is about 4 years ago. While we were there, we had a high rate of mortality amongst our retinoblastoma patients, a lot of group E, a lot of orbital retinoblastoma. In fact, our mortality rate was close to 100%. So we started Burundi's first chemo program with increasing etoposide and carboplatin with a lot of help from ocular oncologists, because I'm not one. And we saw a real big improvement in survival. And this is one of the first little boys that I operated on. So happy to be in San Antonio now and talking with you guys. Maybe someday in the future, I'll be back there in Africa. So I want to talk about ERMs, epiretinal membranes. These are near and dear to my heart. And we're going to go through a few cases, and we're going to ask about 5 questions. So this is a 66-year-old man, came in to see me 2 years prior to this photo. And he's got this epiretinal membrane, which you can see here, a little bit irregular on the surface of the retina. Great vision. Here's his OCT. You can see the hyperreflective membrane. You can see cystoid macular edema and some retinal folds. His question was, well, Doc, how common are these epiretinal membranes? And so we'll start off with one study out of Wisconsin. This is from a few years ago, a 99% white population, not universally applicable. But for folks over 63, about 1/3 of them have an epiretinal membrane. So this is probably one of the most common retinal conditions out there. If you further subdivide it by age, it goes up to 50% or more in that over 75 group. So very common. Answer is, yeah, this is something we see virtually, well, probably every day. Going back a little bit, I first saw him 2 years prior for a PVD in this right eye. He had flashes, floaters, got referred in by an ophthalmologist in town. 20/50 vision, had a bit of a cataract, no holes or tears. Went in for cataract surgery a few months later, came back with, not for this right eye, but the left eye actually had flashes and floaters, PVD in that eye. But interestingly, his right eye had a small operculated tear. And so that might have been the reason why he got the epiretinal membrane. Perhaps it was cataract surgery. I went ahead and lasered it. He was completely free of symptoms. And a month after that laser, he still looked okay. I saw him again 6 months later. He was not bothered at all. In fact, he noticed no metamorphopsia even when he covered his other eye. And this is his last visit with me. I never operated on him. And he moved to Utah. So I don't know how he's going to do going forward after this year. But he was very happy. So I decided not to talk him into surgery. And I don't know if any of the surgeons on the panel, maybe we can talk about this at the end if there's some time, would have operated. So let's move on to my next patient. 64-year-old man, retiree, avid woodworker, vision's 20/40. Here's his OCT. And he actually does have symptoms, but only when his other eye is covered. And he didn't know he had this until his optometrist referred him to me. So his question is how bad is this? Do I really have to have surgery, doc? So there's a lot of staging systems out there for epiretinal membranes based on OCT, and this is probably my favorite so far. I call it the Govetto based off of the first author. Stage 1 has an epiretinal membrane, but great preservation of the foveal pit, as you can see in this image. Stage 2, you have flattening of the foveal depression, and you may or may not have some underlying, this is called the cotton ball sign, some loss, or kind of looks like a little mini explosion within the ellipsoid zone and external limiting membrane up here. And stage 3 is probably the most unique part of the staging system. They coined this term called the continuous ectopic foveal interlayers. And you can see here the internuclear layer crosses over the foveal center as well as the interplexiform layer, which don't belong there. And assuming you have your OCT well-centered, this is what they characterize as stage 3. And stage 4 has all of stage 3 plus some disrupted retinal layers, which you can see here. And this is a lady who did not want surgery for 2 years and finally did end up having surgery with me. But so this is a retrospective study, about 180 eyes. And they went back and characterized their eyes based on the staging system they created. And as you can see here, CME did not really was not part of the staging system, but it did go up as the stages increased. So we see about 2% in their stage 2, 13% in stage 3, 41% CME in their stage 4. And you can see the visual acuities also decreased as the stages increased. Ellipsoid zone disruption went along with that visual acuity decrease as well. So I wasn't trying to be coy with the patient or anything like that, but I basically told him, his was mild, and we decided to watch at that point. So I'm going to walk through a couple of his OCTs for you, or 3. So here he was in 2018. I saw him again a few months later. I skipped over that one because it hadn't changed very much on his OCT and his vision wasn't bothering him at all. And I said, well, why don't you just come back and see me when your vision starts bothering you? And so he came back in 2020, had vision of 20/60. You could see he's probably around a stage 3 here because we see the INL and the IPL somewhat crossing the center. He's got a little subretinal fluid as well. What's interesting on his autofluorescence is you could see where I put these arrowheads that there's some hyper autofluorescent lines that correspond to the original locations of his superior temporal and inferior temporal venules. So these actually have migrated in response to the tangential attraction from the epiretinal membrane. So he did want surgery at this point. And a year later, actually this month, he came in, he's very happy, 20/20 vision. And you do see that he still has these ectopic inner layers crossing the fovea. And this is a pretty typical post-op appearance for my patients. So here's my next patient. And 67-year-old lady loves horseback riding and has had a membrane peel in her other eye. So she's very aware of what's going on here. She's got a little bit of metamorphopsia, great vision, 20/25. Here's her epiretinal membrane. And her question for me is this going to get worse? And so if those of you who know me know that this is kind of one of my pet things. And I had noticed this sort of tendency for folks that have a vitreopapillary attachment to seem to have a higher rate of progression. But I finally found a couple of studies that might back up my theory here. So they're both out of Korea, this one, and they're both retrospective. But this is just 62 eyes, 24 months of follow-up. They have their own criteria for stability and progression, which we won't go into today. And 3/4 stayed the same or got better. About 20% got worse on OCT. And of those that got worse or had progression, about half of those lost vision as well. So then they divided them up based on PVD status, complete PVD or not a complete PVD. So about 4% of those with a complete PVD. So 52 patients out of their 62, 2 out of those progressed. And about 4 out of 10. So again, this is a small study retrospective, but there's definitely a difference, according to them, tenfold between those who progressed and those who didn't based on PVD status. Here's another study, Quan. They looked at ERMs after cataract surgery because there are some thoughts about progression of epiretinal membranes after cataract surgery. 24 months of follow-up, much bigger study. Again, retrospective, 800 eyes. they divided them into 3 categories: no PVD, partial PVD, and full PVD. So if they had no PVD, they saw progression at about 3%. They had a full PVD, again, about 3%. Partial PVD was at almost 14%. And graphically, you can see that here. And they had more data to support their conclusion that maybe there's a 4x higher risk for progression. So what did I do? Me being the conservative surgeon that I am, and she was not terribly bothered by it, I watched her and I answered her question, which is what we just talked about. So this is her in 2017. She is what I would call stage 2 here. And she lost a couple letters. None of these are best corrected visual acuities. A lot of these are my satellite clinics. And so she possibly could be seen better than that. And around 2018, so about a little less than a year after starting to see her, you could see that she started to develop these continuous ectopic foveal interlayers. Again, her symptoms are just mildly getting worse. She was one of those ladies that said, yeah, if I cover up my other eye, I can tell, but it's not bothering me. So we kept on watching. So in 2019, she finally said, okay, this is driving me nuts. Her vision dropped at that point too. And so did a vitrectomy. She followed up a month later. And surprisingly, I actually saw an improvement of her ectopic foveal interlayers. And I haven't gone back and looked at all of my cases. This might be the only one where I've seen improvement. Maybe it was because it had just recently changed. Vision's 2025. And I don't know if it's a pandemic or just happiness with her vision. She never followed up with me. So as far as I know, she's still very happy. And so here's our next patient. It's a surgeon that I saw when I was active duty military, and 2100 vision. And his chief complaint was, well, I'm starting to have a little trouble operating under the microscope. And I don't know if he was just, I don't know. I'm just glad I wasn't one of his patients. So he said to me, how much will my vision improve if I have this surgery? So that's a tough question to answer. And part of it's just isolating if there's multiple items that are contributing to vision loss. And thankfully for him, it was just his epiretinal membrane. So there's quite a few studies. This is just a small fraction of all the studies that look at predictors of postoperative visual function. Severe disorganization of the retinal interlayers is associated with worse final visual acuity. There's several associated with better final visual acuity with ellipsoid zone integrity, and then those cone outer segment tips. That line sometimes is hard to see even in normal individuals, but when you can measure it, in the higher integrity or a longer continuity is associated with better visual acuity. That's final visual acuity. Conversely, if you look at gainers, the people that gain the most vision, well, if they started out with worse vision, they had a lot more room to improve, and they did. And then if they had greater macular volume, and if they're pseudophakic, for some of these studies that are a little bit shorter, a lot of these patients get cataracts, 90% within 2 years will after surgery. So if they started out pseudophakic, they tended to do better, certainly area under the curve for vision. And then a thicker internuclear layer did correlate to worse metamorphopsia. There's a lot more studies we could go into to talk about this. So to answer his question, I said, based on his vision, OCT, I think he would, I did give him a rough estimate, and we could talk about what that talk is like. It's long and detailed, especially for someone like him. So his pre-op vision was 2100. He started following me after I came back from Africa. I'm in private practice now, and he's up to 2025 now. And you could see he still has his ectopic foveal interlayers. So here's my last patient, retired nurse, 64 years old. And she's the only patient that I'm presenting whose eye I didn't operate on. Well, I guess it was the first guy I didn't operate on at all, but another surgeon operated on this lady. She had 20/30 vision. She moved to the Hill Country from another state, and the other state, she had been seeing a retina doctor for about 4 years, who was sort of waiting for the vision to drop a little bit more. She also is very hesitant about surgery and said she has double vision when she's driving. She was noticing loss of depth perception, and when she met one of my partners, they agreed it was time for surgery. But first of all, let's answer the question of how do we decide when it's time to operate? And so the answer is, that's a really tough question to answer. And so we put out an informal survey to our DRC, our retina investigators, earlier this summer. We had 63 responses. And I don't know if some of you want to look, we asked them to analyze 5 different factors and how they affected their decision to pursue surgery. So these are their 5 choices, and they could fill in the blank too. If you want to guess, probably most of you are going to say visual acuity was the top factor, and that is the top. It had a plurality of votes, if you will. But more than half of people said that something other than vision is the most important factor, such as metamorphopsia or level of annoyance. And as you go down, you could see the lower ones were macropsia and diplopia, not because those aren't concerning symptoms, but because a lot of us believe that those symptoms don't necessarily improve as much as visual acuity or metamorphopsia with surgery. So my answer would be, again, I didn't see here, and I shouldn't actually ask me this question, would have been, we need a large multi-center prospective randomized controlled trial, which hopefully we will be able to accomplish in the not too distant future. So let me show you her pictures. So she started out February 2016 with 20/30 plus vision, had vitrectomy, vision's not improved yet, had a cataract, vision went down to 2100. Again, that's pretty typical. She had cataract surgery, her vision improved again. Meanwhile, every single visit, I had taken over her care at this point, she is really not happy with her visual quality. She knows that her visual acuity is better. Her symptoms range from double vision. Now that she's had cataract surgery, she's having some positive dysphotopsias. She still has distortion, a little bit of macropsia, and she developed a PCO. She had that YAG. Now she's 20/20, but she's still not very happy. And so hopefully one day we will have some answers as to when we should intervene. So here are some key points. Epiretinal membranes are very prevalent, more than 1/3 of Medicare age beneficiaries. Govetto staging system may become a useful measure, we'll see. Partial PVDs can be a risk factor, I think, for epiretinal membrane progression. That needs to be evaluated in a prospective study as well. And there's a lot of different OCT biomarkers in addition to vision that can assist in predicting vision. And then finally, we do need a large multi-center prospective study to look at the optimal timing of intervention, and investigators at the DRCR Retina are hoping to put something together in the next not too distant future. Here are some of my references, so quite a few here. And this is my family after or during the winter storm. We held up pretty well in the hill country, and I've got some other videos at my YouTube channel there. Happy to answer any questions. I'll go back to a more interesting slide to look at.
Yeah, those were great images, beautiful presentation. I got a question for you from a referring doctor perspective. So if a patient has epiretinal membrane, they've got cataract, their refraction's out of date, you know, what's the order in which you approach a patient like that with multiple things that may help them be happier?
Yeah, no, I love that conversation, because it's really important for them to understand that we don't always know what percentage of their visual loss is due to which item. And the more we can isolate things that are non-invasive, take those off the table, the better. So depending, of course, if they have a really visually significant cataract on exam, then I'm going to push them towards that before even, doing a refraction prior to surgery. But I'm going to push for cataract surgery before epiretinal membrane peel almost all the time if there's some question that that's contributing to their symptoms. Now, if they do have a strong metamorphopsia component, and they have a clear lens, then I'm not going to make them get cataract surgery, although they'll be counseled about the possibility that that will be necessary in the future. But the more I can do things that are either less invasive, or the way I tell them is they're basically buying 2 surgeries just by getting this one if they're over 50. And if there's some possibility that cataract surgery alone would help, I always push that first. Thanks. Dr. Wong, in our discussion earlier today, you mentioned something I hadn't thought of before, which was ask the patient to patch their fellow eye. Could you tell us a little bit more about that?
Yeah, a lot of times, if they may not notice it as they tell you, and they don't know that they have a problem. So if you have them patch their better eye and just say, just do that on a weekend. If you can read and drive and do everything you want to do with that quality of vision, you don't really need surgery. And so somebody like who's 20/40 and such, I usually tell them, well, you need 20/40, better than 20/40 to pass a driving test. So you might, consider surgery if your vision is, down below that level.
I think that's a great point.
Yeah, but I think if you force them to use it, then they sometimes will notice that it's not as, it's may not necessarily be as good as they think. One problem is that, as you alluded to, especially with your nurse, if they improve, sometimes the imbalance between the two eyes actually makes them unhappier.
Right.
Because then they have competing images. Whereas if they're 20/70, maybe their brains sort of suppress that image, and so it sometimes is a case that you may not necessarily make them happier. I would have told the nurse, the surgery was done about as well as you can do, and
Yeah.
that's it's a function of the fact that your retina wasn't perfect. So there's not much more that you can do for a patient like that.
No, I know. I counsel a lot, and you're right. You can't go back in time. And I think your point of patching up the fellow eye really kind of forces them to decide if this is bothersome now, rather than just ignoring it, kicking the can down the road, and then like that lady waiting 4 years and it's too late.
Right, because basically, if you wait too long, sometimes there's some permanent. I just tell them it takes a lot longer to recover. If you had it for 3 years, it's probably going to take you 3 years to get rid of all your distortion. And so, it does force them to sort of make a decision.
Yeah, you had some great surgical outcomes here, great counseling. I tell patients 20/40, we start talking about surgery. At 20/70, I twist your arm. But it's really how bothered they are, because if they're not bothered, it's hard to make an asymptomatic patient feel better, right? And so I do 20/25s in all our United pilots that can't pass their FAA to fly the 737 MAX. So and they're the happiest patients. So I don't mind pushing the envelope, but where you get into trouble is sort of convincing people into surgery that really didn't know they had a problem to begin with. So.
Yeah, that's a great point. Thanks, everyone. I'm going to turn it over to Dr. Scheffler, whose talk I'm really looking forward to.
Okay. Thank you so much. Great talk. That was awesome, Daryl. Thank you. All right, so I'm going to switch gears a little bit. Can everyone hear me?
Yes.
Okay, excellent. All right, I'm going to switch gears a little bit and talk about some weird stuff just to finish off the night. We'll make sure we finish on time. So I'm going to talk about how to approach some tumors that you'll see on photographs and OCT when you're in clinic in the posterior pole. So this is just a kind of random smattering of all sorts of weird stuff that I see and do every day in clinic. Lots of spots and dots and holes in the retina and all sorts of weird pigmented stuff. So I do tumors of the eye, as I'm sure many of you know, and focus my practice on that. So I'm going to talk about how to kind of think about some of the amelanotic yellow and orange things that you see in the back of the eye, some more commonly and some less commonly. So everyone knows what this is, right? Here's a spectral domain OCT image of the macula with all the layers outlined. And in truth, just like other kinds of retinal pathology, we can see both benign and malignant processes in really pretty much all layers of the back of the eye. So we see different types of tumors that go to the vitreous. We see different things in the various layers of the retina, some of which are, very concerning and very malignant, some of which are much more benign. We can see abnormalities that have to be distinguished from tumors in the RPE. We see all sorts of very bad stuff, really probably the worst things that happen in the back of the eye in the choroid, including things like melanoma and choroidal metastases that come from other primary cancers in other parts of the body. And we even see abnormalities in the sclera. So I'm going to take you through some examples of some of these, just a handful since we have a short time, but just to kind of give you a way to kind of think about how to look at these. So one major thing that I use every single day to help look at lumps and bumps in the back of the eye is something called EDI-OCT, or Enhanced Depth Imaging. And this is actually a modification of kind of regular spectral domain OCT that was developed about 10 years ago. And it was really first described by Rick Spade, who's a colleague and friend of many of ours from New York. And what he noticed was that when you advance the lens of the image as the operator forward toward the eye, and many of you who've done OCTs yourself have probably seen this, the image inverts. So all of a sudden it looks upside down, whereas normally the regular image is upright. And the focal point, or the kind of 0 point, is kind of right at the inner surface of the retina. But when you move the lens closer to the eye, what happens is it actually inverts. And the second thing that happens is you start to see that the deeper layers of the fundus are more in focus. So you can start to see details in the choroid, and you can even start to see some details in the sclera. So this is a modification that turned out to be very useful. And then what happened is that Heidelberg and other companies that make these machines actually developed a software update that actually enables the operator to take these images and for them to come in as an upright, normal appearing image, so that we can use it to look at diseases that originate or have important roles in the choroid or in the sclera. And this is actually true for lots of retinal diseases, things like central serous or other pachychoroid diseases, where it's important to understand what the thickness of the choroid is and what's happening in the choroid and the choriocapillaris. And it's especially important for tumors that invade the choroid and extend even posterior to that. So that's something useful that we use every day. So you can use this modality to even see the sclerochoroidal junction, although it's not perfect all the time, and to measure the height of lesions that we see in the choroid or the retina. It does have some limitations in that you can't see things that are more than about 2 millimeters in thickness. It doesn't image totally consistently the sclerochoroidal junction perfectly, depending on how far back it is. And it doesn't help you with sideways measurements, but it is certainly something that's very, very useful and very accessible. Oop. So we're going to start in the inner retina and move to the outer retina. So one of the things that I do every day, that's my job, is to actually distinguish scary, malignant looking things from more common things. So we'll start with the inner retina and kind of move more posterior. So here's a kind of nodular thickened area of the inner retina, malignant tumor or not. Anyone on the panel want to jump in? What do you think? Is this going to kill our patient tomorrow? Tian, I see you smiling. I gave it away with my accidental slide advancement. Oh, you're muted.
Sorry, I missed that, but it's
Anyone?
benign.
It's benign. Good. Okay. So this is actually a cotton wool spot, right? So we see these all the time in patients with diabetes and hypertension. It's an area of hyperreflectivity in the inner retina and the nerve fiber layer from an area of ischemia, from kind of impedance of normal flow in the precapillary arterial flow. So it appears as this thickening kind of in a nodular way of the inner retina. Could look like a tumor if you didn't know, if you didn't have a fundus photograph to look at, but totally benign. And there are other things that cause thickening or kind of, round elevation of the inner retina too, that are not so scary and not going to kill a patient. Something like this. Anyone on our panel want to jump in and tell us what this is?
Looks like a myelinated nerve fiber layer here coming off the disc.
Excellent. Thank you, Dr. Shaw. So that's a myelinated nerve fiber layer, right? So if you do an OCT through this, you'll see that it's kind of a similar picture, right? You get increased hyperreflectivity of the inner retina, and that's because there's myelin. It's like a sheath on the nerve fibers that normally develops in the 8th and 9th month of gestation, but stops just short of the eye in the lamina cribrosa, but in some patients actually ends up inadvertently extending into the eye, resulting in these kind of feather-like projections that you can see on a photograph or on an OCT. So these are mostly congenital. They can actually rarely be acquired. They're basically nerve fiber cells with this covering, and it normally happens much more posteriorly in the optic nerve, extending from the chiasm, but just to the lamina cribrosa. But when it happens abnormally, it extends into the nerve fiber layer within the retina. And these obscure the retinal blood vessels and look on the OCT as we discussed, and they're almost always completely asymptomatic. So something else to distinguish from more scary things. But then there are also some things in the retina that are more tumor-like, not necessarily malignant, but more tumor-like. So here we have another kind of whitish, fluffy looking thing in a 57-year-old asymptomatic lady that also obscures the vessels. You can kind of tell that it's elevated because of its kind of round curved shape. And on our OCT right through it, right, we can see that it elevates the inner retina, but it actually doesn't quite involve the nerve fiber layer. It's actually in the deeper layers of the retina, kind of just posterior to the nerve fiber layer. Anybody want to take a crack at this? We're going from more common to more rare. So now we're getting into the weird stuff. So this is called a P-scrap, which is a kind of a crazy term coined by Carol and Jerry Shields in Philadelphia. And that stands for presumed solitary circumscribed retinal astrocytic proliferation. Kind of a crazy long name, but kind of easy to remember because of the good mnemonic. And this arises, as I said, from the mid-retinal layers. It's benign. It's usually solitary. When we learn about these lesions in residency, it's usually in association with more systemic disorders, often genetic disorders like tuberous sclerosis. But we can actually see these sporadically in normal, healthy adults who don't have any genetic diseases, and this is typically what they look like. And they're actually, the name is kind of a misnomer because they don't actually come from the astrocytes. They come from the retinal layers just posterior to the nerve fiber layer, as I said. But just another example of a situation where the OCT is really very helpful. Okay, so now we'll look at something that's a little more common, also occurs in the retina, also amelanotic. Here's a patient of mine who's a 25-year-old gentleman from Louisiana who came to see me about 3 years ago with decreased vision, about 2100. And you can see we have this kind of whitish, yellowish lesion right here overhanging the optic nerve with these sursnate rings of exudate and fluid and even a couple little hemorrhages, kind of if you look closely both on the surface of the lesion and within these areas where there's exudate, right? Kind of a dramatic looking thing. And when we look at the OCT through it, we can tell that this arises from the retinal layers, right? Because the choroid's actually pretty intact behind it. Obviously, there's lots of optical shadowing, but the area where the pathology is within the retina. And of course, we see a lot of that fluid and exudate that we saw in the photograph. And so this is a vascular lesion. We can see on the ultrasound, which is a super important tool that I use to measure tumors and understand their characteristics all the time. We can see on the ultrasound that this involves just the retina, right? Because the choroid is totally intact right behind it. And it does have a couple little areas of calcification within it, which you can sometimes see with these vascular lesions. And so we treated this patient. We actually have been treating him for several years since with a combination of both PDT, anti-VEGF, and steroids. And he actually is doing terrific. His vision's 20/25 in this eye. He's got a little bit of a PSC cataract. You can kind of see the shadow here. And this is what's called a retinal capillary hemangioblastoma. More common than some of the other things I talked about, but not as common as cotton mole spots, certainly. But this is a vascular tumor that also occurs within the retina. It can also occur within the context of systemic syndromes like von Hippel-Lindau, or it can occur sporadically. In this case, this young man just had a sporadic lesion. It's benign, it's vascular, and it causes lots of vision loss from exudation and subretinal fluid. And it's mostly in younger patients. The good news with these lesions, we've developed a lot more experience with them over the last 5 or 10 years and gotten much better at dealing with them because they are very pro-inflammatory and cause lots of problems. We treat them nowadays with a combination of photodynamic therapy, which is a special light treatment, as well as anti-VEGF and steroids. And you have to do it in a very specific sequence so that by doing the laser, you don't actually make them worse. So, so these patients can actually have a very good outcome compared to kind of how it was, I'd say 20 years ago when I was in training. Okay, so now we're going to move kind of even deeper within the retina to the choroid. There's all sorts of very interesting stuff that happens in the choroid, particularly in adult tumor patients, many of which are very kind of malignant and scary looking. But we're just going to talk about a couple things today, also amelanotic lesions we see. So here's a 50-year-old lady who came into my clinic with blurry vision of about 20/40. And she's got this kind of orangey lesion here along her superior arcade with these sort of very sharply demarcated borders. And you can see on her EDI-OCT that we can actually get a pretty good look at the lesion here. It's within the choroid, right? It's underneath the retina, and it has these sort of linear formations and kind of round vascular channels. Anyone on our panel want to take a crack at it?
Is the ultrasound hyper-echoic on this one?
Okay,
Because
you
that
asked,
would help.
I'll give you more. Fair enough. So
Oh,
here's
cheat.
cheating's allowed. So here's another patient with actually the same form of pathology, and just kind of to show an example of these sort of linear, what we call lamellae, sort of lining the layers of the choroid in this very linear fashion. And my watch is talking to me. Oh, my watch just told me I'm nice. Okay, lovely. And we can see that her vision is blurry, right? Because she's got a whole bunch of fluid under her fovea with this kind of shaggy photoreceptor type look, because this is obviously kind of becoming a chronic problem, and this fluid is getting worse and worse. And Dr. Shah asked for an ultrasound. So ask and you shall receive. What do you see?
Yeah, so I mean, when you see that hyperechoic change, and then demographically also in terms of the patient you described, it seems like a choroidal osteoma would be
Right. Great
up
job.
on
Great
my
job.
list.
Yep, great job. So exactly as Dr. Shah said, right, this is very, very hyperechoic. It actually shadows so much that everything behind it on the ultrasound, all the sound waves that hit it actually bounce right off, and it creates complete optical shadowing. Absolutely none of those sound waves can pass through. So that's a very classic, particularly when it's kind of flat and sheet-like like this, for a choroidal osteoma. So this patient had a choroidal neovascular membrane associated with this osteoma, which we treated with injections, the same as we do for other patients. And here she is 5 years later, her vision's 20/20, and she's doing great. So this is a benign lesion. It actually occurs from true ossification of the choroid, so bone formation within the choroid. It is most common in young women, as Dr. Shah said, usually peripapillary, and it can rarely be bilateral. And in those cases, we actually work these patients up for disorders of calcium metabolism. And the most common way that these patients lose vision is either with decalcification over time with RPE loss and atrophy, or from choroidal neovascular membranes, which can lead to vision loss from subretinal fluid. And so this patient, was an example of that. And they tend to actually do extremely well with anti-VEGF therapy, assuming that they kind of come to us early enough. And the key finding, I would say, on the OCT for these patients is that are those linear lines that I was showing you, those bony lamellae, which are actually thought to be kind of lines within the layers of bone that that deposit within the choroid. And you really don't see that in really any other form of pathology in the choroid on that EDI-OCT. So moving along, we're going to go even more posterior to the sclera. And you'll remember that I mentioned that with the enhanced depth imaging, we're able to actually even image the sclera and certainly the sclerochoroidal junction, which helps us look at things that are in the posterior pole, but more posterior. So here's a 79-year-old asymptomatic male that I saw a couple of weeks ago in clinic, came in referred by one of our optometry partners in the community, who saw this kind of orangey yellow looking thing up here, supranasal, but the patient had absolutely no symptoms at all. And you can actually see on the photograph that the patient also has a couple of choroidal folds associated that seem to be almost kind of emanating from it. And then we see a similar thing in the other eye here, superiorly, above the superior arcade, kind of orangey yellow with kind of feathery margins. Dr. Shah, you're on a roll. Here's our ultrasound, right? We kind of see some very similar, very hyperechoic elevated area here with same thing, optical shadowing, looking also kind of calcific. What are we thinking?
So suprachoroidal calcification is probably the only thing I know that fits in this category, but this is one I would send to you.
I appreciate that. So here's our EDI-OCT, and what's really cool about this image is that it kind of shows you where this pathology is. So if you follow the choroid in this image, you would actually see that it's actually fairly intact and it's being compressed by something that really is actually in the sclera. And in this case, it's got kind of what we call a tabletop configuration. It's kind of rounded, but with a kind of a square top. That's the one in the right eye. And then in the left eye, kind of same thing. It's kind of more round, more like what we call a rolling hill, but it's really, the abnormality is really in the sclera kind of pushing on the choroid, and the choriocapillaris compressing. So exactly as you said, this is a sclerochoroidal calcification. These are actually fairly common. They happen mostly in older folks because this kind of calcification is actually just thought to be something related to aging, kind of like those calcific plaques that you can see on the sclera interiorly as people get older. They are often symmetric and usually supratemporal. So this patient had one supranasal, but they're most commonly supratemporal for unclear reasons. And almost always patients are asymptomatic, and you don't need to do anything with them other than reassure them. They can enlarge over time, like many age-related changes. So that's one thing to keep in mind in case you see the patient back 5 or 10 years later and it looks a little bit larger. Very rarely, these can be associated with systemic conditions if they occur in patients at much younger ages who have rare metabolic diseases, but most of the time, this is something that's not concerning at all. So just to sum up, take-home tips about OCT and enhanced depth imaging. Think about when you're looking at a patient who has any kind of elevation in the retina, what layer you see that abnormality in. Is it in the inner retina? Is it in the outer retina? Is it in the choroid? Is it in the RP? Is it in the sclera? We think about, are things flat? Are they thickened? Are they elevated? A general rule of thumb in terms of referring to an ocular oncologist is that if you see something that is going off your screen, which means it's 2.3 millimeters or so or thicker, it's a good idea to send that patient along. And then you want to look for the surface features. What's happening to the retina above the lesion? Is it atrophic? Is there fluid? Are there drusen? Is it elevated? Is there a ton of fluid? Any kind of real disruptions in the retina overlying a lesion in the choroid or in the sclera is more concerning. And then, of course, morphology. These things come in different shapes and configurations, and part of distinguishing those mostly just comes with practice and years of experience. So just one really quick slide to kind of talk about all the really neat things that that we're able to do here at RCT. So we do lots of really cool clinical care for people with ocular tumors all the way from age 0 up to 100, everything from intraarterial chemotherapy for retinoblastoma to on-site biopsies and massive amounts of genomic research in patients with uveal melanoma, to tons of really cool research, collaborative research with colleagues around the country in the genomics of tumors, in the use of anti-VEGF therapy for radiation retinopathy, trying to make our patients' visual outcomes better, to brand new strategies for the treatment of ocular tumors. And I'm lucky and blessed to be able to have just a wonderful, wonderful team here who help me do this every day. So for our optometry colleagues on the call, I would say when in doubt, refer over and have us take a look at any patient who's got anything elevated on an OCT or a photo, particularly in pediatric patients. We do tons of co-management for benign diseases. So it's great to kind of send a patient over. We kind of take a look, say, hey, this is okay. And then we kind of share care moving forward. We have full-time coordinators here who take care of all our cancer patients. And this is the phone number if you want to take a picture of the screen if you need to reach any of my coordinators with questions. And of course, you can call or email me if you have any questions about weird stuff anytime. And I already text with many of you on the call, like you'll shoot me a picture and we kind of talk through stuff on text, which I think is super helpful. So hope everyone enjoyed it. We've got 3 minutes to spare. So hopefully James is happy with it. Thanks everyone.
Very happy.
Dr. Scheffler, can I ask a quick question?
Of course.
So I read this paper a while ago about sclerochoroidal calcifications, and the authors recommended doing a workup. And I've done that on a number of patients and it's been totally negative. And so it sounds like you kind of use an age cutoff. How do you decide when to order a workup?
That's right. That's right. So 70 and up, I typically don't work it up because that's really the age range where it's most common and mostly age related. The systemic metabolic disease where it's really a problem is really in young folks. So things like Bartter syndrome and Gittleman syndrome, that's really, typically a much younger age range. So if it looks very classic and it's an older patient, you really don't have to work it up.
Thank you. I really appreciate that.
Good question.
Okay, everybody. Yeah, you got anything, Amy?
No, I think there were some on the chats, but I guess they were all taken care of.
I think they were taken care of.
Okay, awesome.
We have excellent chatters.
Awesome.
Wow. I learned, this was a great talk tonight, a great CE. I learned a lot. Dr. Baskin's ERMs, Dr. Benz's myopic CNVMs, and then Dr. Scheffler's tumors sort of on top of, in and under the retina in all places. It was super informative. I learned a lot. In terms of, like Dr. Scheffler mentioned, in terms of referring patients, you can go to the website, retinaconsultantstexas.com. It has how to refer. You just click on a button, how to refer a patient. Number 2, you can call our 1-800 number, 1-800-833-5921. Or you can do a old school sort of fax referral. But again, using that image portal, when you're communicating with us really, really helps a lot. So website, call or fax, all are there. In terms of getting your credit for tonight's CE, if you signed up for the credit, if you signed up for it by email, you should be all set. In other words, there's nothing else you need to do in terms to receive your CE credit from the optometry board. And then just for the future to mark on your calendar, we will have 2 more this year. We'll have 2 more 1-hour CE courses. One is October 5th. They're both 7 to 8, and the other is December 7th. So 2 more CEs that'll be in this format, Zoom style. for 1 hour credits. There's a lot of people to get that December 7th. You need to, end of the year coming up, you need another hour to put it online. Any questions or problems, Sarah Barbatano does everything for us. She's Sarah Barbatano at retinalconsultatetexas.com. Call us, find us anyway. Thank you again for entrusting the care of your patients to us. And we welcome, it was great to welcome our retina consultants of San Antonio, now retina consultants of Texas, colleagues from San Antonio. We're happy to have them. And we had a great CE tonight. I learned a lot. I hope you did too. And thank you for participating very much. See you soon. See you October 5th at the latest. Thank you.